screen, go ahead and hit OK. And then I now am introducing and spotlighting Dr. Cosette Lyons-Jones, who will take us through the presentation.
Good morning, and thank you so much, Antoine, for that introduction. I'm so honored and humbled to be here before you, to be able to share. I am an internal medicine physician, and so diabetes is what we do every day. Among other things, this is like one of the top diagnoses that we see, unfortunately. So this is an important subject that we're going to tackle, but I'm going to hit it in a different way than we're accustomed to seeing it. So you're going to be probably pleasantly surprised and enlightened on some things that you may have heard about, but I'll give you some context for it so that you can see how it relates to the big picture of both prediabetes and diabetes. So let's get right to it. I'm gonna bring up my slide deck. And can everybody see it? See my slides?
Yes.
All righty. And I'm going to, a lot of things keep coming up. I guess whenever anyone enters the room, it flashes up on my screen. But prediabetes and diabetes prevention and general management is the topic. And let's see, as far as the goals, our learning goals for today is to learn the difference between prediabetes and diabetes, look at the various risk factors for diabetes, and we'll go in depth about a couple of them, in particular, obesity and fat distribution, because we know a lot more information today than when I was going through training. And we know that fat is metabolic. It's not just something that's just sitting there, you know, in your body. It's active, it's secreting things, it's being acted upon, and it's influencing our health. Symptoms of diabetes and how we make the diagnoses, the various tests that your doctor may order to get to the diagnosis of diabetes, the various complications of both prediabetes and diabetes, how to prevent these diseases, and some general tips to manage the disease. We will not be going in depth about the medications on today. That's beyond the scope of this presentation. If you like this presentation and AARP wants me to come back, I'll come back and do that one for you. But this is pretty meaty already, so let's get going. How common is diabetes? Over 37 million people in the United States alone have diabetes. And another 500 million have it across the world. This number is expected to rise to as high as almost 800 million people by 2045. And the most common type of diabetes nationwide and internationally speaking is type 2 diabetes. So it is a global epidemic. When we talk about prediabetes, this is the precursor to diabetes. So it's a condition where the blood sugar levels are high, but they're not high enough to make the diagnosis of diabetes. Typically, a person is asymptomatic, meaning they have no symptoms, but there are some telling signs on examination when you come into the office to see your physician that we can look and say, I wonder, you know, if something's going on here. The photos that I have on the screen shows you some discoloration, for example, around the neck area, can happen in the underarm area and the groin area. And this discoloration has this fancy term, it's called acanthosis nigricans. And this is a hallmark that's associated with diabetes and can give us a clue that something is going on even before we do a blood test. Blood pressure elevations above 130/80 is associated with metabolic syndrome, which is a constellation of a lot of different symptoms, and including obesity, abdominal obesity, and high cholesterol, high blood pressure, elevated sugar. And so when you have that constellation of all of those things coming together, that, you know, you see someone with high blood pressure, you wonder, are these other things also present? And that points to what we call metabolic syndrome, which we'll talk about a little bit more later. Increased abdominal, you know, or waist circumference is another telltale sign, and there's a threshold, and we'll get to that also. When a person presents with these symptoms that you see on here, increased thirst, we call it polydipsia, or increased urination, more frequent urination, polyuria is the fancy term for it, fatigue, blurry vision because you have excess sugar in the body that you're not metabolizing properly. And so the sugar goes behind the lens of the eye and it can cause blurring. Unexplained weight loss. You see it more commonly in type 1 diabetics, which is the younger people that presents with it. And type 1, the difference between type 1 and type 2 is that with type 1, there's a production of insulin issue. So there's a deficiency, or a lack of insulin. Whereas in type 2, it's more so the body's response to the insulin that's being produced it's not as sensitive. You have a resistance to that insulin. And oftentimes that's associated with the presence of obesity. So unexplained weight loss, you see it more commonly in type 1 diabetics, but you can also see it in type 2. So if you have someone, you're like, this is unintentional weight loss, it's just coming off, and you're wondering, and they have some of these other symptoms, they're drinking, and no matter how much they drink fluids, they still feel thirsty, and they're going to the bathroom a lot. They may even have cuts and sores that are slowly healing. It's something to think about, that there's a possibility that someone who may have known they had prediabetes has progressed to diabetes. When the diagnosis of prediabetes is made, it's made in the same way as diabetes, but the threshold, the numbers, the cutoffs are different. But the three different ways that we make the diagnosis in the doctor's office is we look at a fasting sugar, meaning you fast for at least 8 hours, and then you just check the sugar and see where the cutoff is as far as if it's ranging between 100 and 124, then we call it prediabetes. There's a test called the oral glucose tolerance test, which is a sugary solution that a person can drink. And, it's like 75-gram load of sugar. And then 2 hours later, we'll test the blood to see what happens with the sugar, how the body handles that sugar. Now, if everything's in order, the insulin should be able to handle it and bring it down appropriately. If not, you'll see a range in pre-diabetic stats from 140 to 199. A hemoglobin A1C is a test that we use to make a diagnosis of diabetes or prediabetes. It also is used to track how well someone is being managed once someone is diagnosed. And you want to see the effectiveness of the treatment, whether it's lifestyle changes and or medications. The hemoglobin A1C hemoglobin is on red blood cells, and red blood cells live about 120 days in your system, and it's floating around. So as long as that red blood cell is floating around, the sugar that's attached to the hemoglobin of that red blood cell is in your system. So you're clearing it out about approximately every 3 months. So when a doctor orders the hemoglobin A1C, it's telling you your average blood sugar level over the past few months, over the past 3 months. And I hope that makes sense. And it makes it, so that it's not just some random number. It's something that if you are not testing your sugar, say if you are pre-diabetic or you're diabetic and you just are needle phobic, you're like, I don't like doing all that stabbing or whatever, or you just are non-compliant. You're like, I'm not going to do it. Whatever the reason, you're not testing at home, we can do the hemoglobin A1C and kind of look at the average, how sugar control over the past couple of months. With prediabetes, a lot of people think, well, I come in, I find out I'm a pre-diabetic, and each time I come in every few months and I get retested, I'm still a pre-diabetic, so I'm okay. That's not necessarily true. You can still have organ damage even in the pre-diabetic state. So there's a continuum of elevations of sugars where you have damage going on, and that sugar is beating on the various organs inside the body. Excess sugar is a toxin. And so it's beating on your nerve, endings. It's hitting the eyes, it's hitting the kidneys, it's hitting the vasculature around the heart, it's hitting the vasculature, the vessels around the brain. And so you can have end organ damage initiated even in the pre-diabetes or pre-diabetic state. So we want to take it more seriously. I tell my patients, if I tell you you have prediabetes, you may as well look at it as I just told you you have diabetes until you do the due diligence to reverse that in terms of lifestyle, diet. You hit it as if you've just been told you have diabetes, because that's how aggressive you need to be to reverse this thing so that you don't progress and don't get this damage or don't progress to full diabetes. Now, I thought this was a pretty interesting slide. When we're talking about risk factors, there's many risk factors and we're going to cover them. But one of them is, we talk about obesity and talk about being overweight. And I know your doctor talks to you about your BMI, your body mass index. And there are, pros and cons to using the body mass index. It's not a perfect number, right? And everybody's body type is different. But I want to look at fat in a different way. I want you to see that where fat is located, it matters. There's two different types of fat. There's subcutaneous fat and there's what we call visceral fat. When we talk about subcutaneous fat, that's the fat that's just right below the skin, that we're accustomed to seeing. When you're talking about visceral fat, that's your intra-abdominal fat. It's deeper and it's more serious. It actually has a higher risk associated with it health-wise, because if you look at this third, like the red emoji, he doesn't look too happy, right? He's like, something's wrong. What's wrong is that you have a large amount of visceral fat that's there, and in that, it's overlying the organs. You can see that it's overlying the liver and the kidney and pancreas, all these organs, and that's not a good thing. Visceral fat causes inflammation. Inflammation is bad. When we're going to talk about that in a later slide. With visceral fat, typically it composes about 10% of the total body fat. So if you measure and you get your total body fat percentage, then subtract 10% from that, then you can, estimate what your visceral fat is. Visceral fat, luckily, is something that can be quickly removed. As you make lifestyle changes, the visceral fat is the thing that reverses more quickly than the subcutaneous fat. We hear different things like intermittent fasting, has been put out there as something that people are touting now for weight management. There's pros and cons to that, but it has been associated with reversal of visceral fat development in the body. Improvement in sleep actually improves your visceral fat and stress reduction. And we're going to talk about both of those more in depth in a moment. Trans fats, things like baked goods and processed foods and fried foods, eliminating those things also reverses and reduces the amount of visceral fat in the body. But it's important to talk about visceral fat because it can infiltrate into your liver. You've heard of fatty liver disease. Fatty liver isn't just a term. It's something that's serious, and it can progress to liver cirrhosis like alcoholics get. It can also progress to even cancer of the liver. So you want to not just look at these as terms and that have no meaning attached to it, but understand the significance behind these terms when your doctor says, well, your liver tests were a little elevated and we did an ultrasound of your liver and it does show some fatty infiltration in the liver. But it's not a big deal. It is a big deal. This is something that can progress if you don't make some lifestyle adjustments. The other important thing about fat is not only where it's located, but where it's distributed. And so you notice men have a different way of presenting when they gain weight than women. Most of the time you see men with what we call an apple-shaped body. You see this apple on this picture here. Women can also present with apple-shaped bodies, but we tend to have a pear-shaped body when we gain weight, meaning where the fat is distributed, the excess weight is more so above the waist when you have an apple shape in men and women. And if it's pear-shaped, the distribution of your excess weight is more so below the waist. The significance of that is that apple shape is actually the one that has a higher health risk associated and tends to be associated with diabetes risk going up. So I can walk into an examination room and without taking a blood test, without doing a finger stick, without getting a history from that person, can gauge that that person's at higher risk or may already have diabetes based on their body shape. Obesity and fat distribution, this, driving it home even more. Remember I talked about you can drink the sugar low solution and then check 2 hours later to see how the body metabolizes it, if it lowers it or not. Well, if a person tends to have more upper body obesity, which is this blue dotted line, they will have higher levels of blood sugar in their body after they have a sugar load that they drink compared to someone that has a lower body obesity distribution. That's the red line that's right here. And both of these have higher sugar levels, regardless of, what time you're checking the sugar after you drink the sugar load in comparison to someone who has a normal body weight. Exercise impacts and influences that. So even if you do a little bit can go a long way. When we look at body mass index, for instance, the bigger a person is, the greater the rate, the higher the rate of type 2 diabetes. That makes sense. When you exercise, that actually lowers the levels. If you're in higher weight people, if you're normal weight, below a BMI of 24, whether you exercise or not, it doesn't really influence the rate of type 2 diabetes occurrence. But as you become bigger, as you gain the weight, that impacts the rate. You see more diabetes occurring. And if you exercise, a little exercise improves your sugar rates, and a lot of burning of calories through exercise also lowers the rate. So you can see here, this is someone who doesn't exercise much, so their rate of diabetes is higher, right? This is someone who exercises a little bit more, their rate of diabetes is improved. This is someone who burns off over 2,000 kilocalories per week, so they're hitting it. And you see that it's impacting and improving the rate of type 2 diabetes. So exercise, whether you do a little bit even, don't kick yourself if you don't hit it. Some people go in trying to really get it hard, but even a little bit goes a long way. When we look at other risk factors, we have family history. So if your mom or your dad, brother or sister has it, you have a 2 to 3-fold increased risk of developing diabetes. If both of your parents have it, it goes up, almost doubles to 6-fold increase risk of developing diabetes. Your birth weight, it says it's a U-shaped distribution, meaning very low birth weight babies and the other extreme high birth weight, big babies are at increased risk of developing diabetes later in life. So you're looking at someone that's a little baby, and we can predict what's going to happen later on down the line. Childhood weight, if you are obese as a child, but you lose the weight before puberty, before you turn 13, then you have the same risk of developing diabetes later in life as the general population of people who had normal weight and didn't have any weight issues. However, if you were obese as a child and you didn't lose the weight right away, maybe you lost it at age 15 instead of at puberty or at age 16, the older you are beyond puberty, you have an increased risk 25 years later of developing diabetes. You see diabetes developing in older adults more commonly. So age, the cutoff usually around 45 is where you see the risk going up more significantly. And then of course, lifestyle. We know that couch potatoes tend to consistently, be at higher risk of developing diabetes. So a sedentary lifestyle. Exercise is important. Smoking, they're looking at smoking as having an association with it. Some of the data that's out there now with smoking is that they see if you give the person the sugar load solution to drink, the oral glucose tolerance test, after they've smoked, their sugars tend to not be metabolized. They tend to have a higher level of sugar when they test the blood compared to someone who didn't smoke. It also is associated with inflammation and other things. Sleep duration, the data is still out on that, but we do know that when you have disruptions in sleep, that you have lower melatonin production in the body, and that actually puts you at higher risk of developing type 2 diabetes. Now let's talk about stress and inflammation. My heart work is brain health, and Alzheimer's and dementia is very important, especially among Black women. And I've even seen articles where they call Alzheimer's type 3 diabetes, because the risk factors for diabetes are the same risk factors for Alzheimer's dementia. And so when you get a healthier lifestyle, a healthier diet, fresh and less processed foods, less fatty foods, less sugar, more fruits and nuts and fish oils and things. These are heart healthy foods. Cardiovascular disease is reduced in a person with that type of a diet. Diabetes risk is reduced, but also your brain health, your cognition is kept intact, and you're reducing your risk of developing Alzheimer's later on. And this is something that has to start in your 20s, but you still can have an impact later in life. You know, if you're older, get on the good foot wherever you get the information and get the enlightenment, then just jump in there and get what you can get. But it's something to be able to look at our children and our grandchildren and nieces and nephews, these younger generation, where they think they can just eat and do any old thing because they don't gain weight when they're younger. It doesn't really hit them till later is what they're thinking. But all of these things are coming together later on. You just don't see the impact immediately. With stress, living as a Black or Latinx or person of color in America or in the world in general and racialized societies is a chronic stress in and of itself. And we now know that chronic stress can impact you psychologically. That psychogenic stress can translate into changes even at the cellular level. So we see that there's aging in our cells prematurely. And in this picture on this slide, we see this is a chromosome where your DNA, your genes are. And we see the tips of those chromosomes, they actually shorten as we age, and that's normal. But that process is sped up when a person is under chronic stress all their life. And I bring this up because when we have to always be conscious and aware of how we present because of our Blackness, that is a stress. And we do that all of our lives from the time we hit, the earth to the time we leave, for the majority of us. And that stress is impacting and aging us at the chromosomal level. It's causing inflammation in the body because you have cortisol, which is your stress hormone. It's spiked up, and instead of cortisol is supposed to go up when you're in fight or flight mode, when you're trying to run from the dog that's loose on the block, and you're like, oh my God, I gotta get away, right? If you're a hunter-gatherer out in the bush somewhere, and and you see the lion, and lion is like, I'm not feeling you, and they're running after you. That's where your cortisol is supposed to spike up. It's a protective, response. However, when you're chronically exposed to stress, it goes up, particularly in African Americans, and it stays up. It resets at the higher level. And that predisposes you to development of inflammation. And that inflammation translates into development of inflammatory conditions like diabetes, heart disease, heart attacks, strokes, things later in life, even poor immune system, autoimmune diseases. So I'm stressing this because we got to do better. We can't be super women anymore. Can't be supermen. We have to be conscious of who is invading our peace and take your peace back, so that you can control this stress and prevent these changes at the cellular level. So race matters. Even if you correct for your weight, there's an increased rate of diabetes among Asians, Hispanics, and Black Americans compared with white Americans. And this ethnic disparity in diabetes is related to a number of things that are modifiable or preventable, whether you're talking about your weight or your blood pressure, biological risk factors, but other things like social determinants of health, the context in which you eat and live and play and work, your neighborhood, the exposures there, the lack of green space, so you can't go exercise, for example, lack of access to healthcare because you don't have insurance. Behavioral factors in young adulthood, which I mentioned previously. These are all things that impact why we see disproportionately this disease in Black and Brown communities compared to others. African Americans in particular have a higher prevalence of diabetes. We tend to present at an earlier age. We tend to have higher rates of complications. And this is what we're seeing is a disparity in management. We have all these tests available. We have millions of medications now that's available, different mechanisms of action. It shouldn't be, this is something that we should be doing better, in terms of our scorecard as people of color, and yet we're not. And so we have to look at systemic and structural racism as a contributing factor, as to why we're seeing a higher prevalence, earlier onset, because of stress and genetic predisposition, environmental factors, and all of that. Risk factors: the westernized diet, that poor, processed, highly processed, sugary, low dense diet. No, it's bad. Sugar sweetened beverages, which we're going to talk about in more depth in the next slide. Vitamin D deficiency is associated with diabetes. Mediterranean diet is actually something that benefits people and lowers your risk. And that's the one with, a lot of fish, fruits, nuts, vegetables, olive oil. It's a good diet option. Dairy products, actually, in someone who's overweight, the studies have shown that increased consumption of dairy products, milk, actually improves or lowers your risk. Consumption of nuts and peanut butter, particularly in women, can lower your risk. Eating more brown rice than red rice in terms of your white rice, you want the brown rice over the white rice. In terms of whole grains, can improve your risk, reduce it. Fruits, it depends on the fruit that you eat. All fruits aren't the same. You have some fruits like blueberries and grapes, cantaloupes, bananas and pears that are good. They reduce the risk. And then you have on the other side, peaches and oranges and strawberries. Those actually are not good. And I made a mistake. Cantaloupe is in the bad category. Apples is in another one that's in the good category. So it really depends on the type of fruit that you eat as to whether or not your risk increases or decreases. And then I hate to say this, because every other day we get a new study about coffee and caffeine. We get a new study about alcohol consumption and heart health and all this other stuff. So in the area of coffee and caffeine, the more recent articles that are coming out are saying that it actually reduces risk of diabetes. So that's like a yay for those people who are caffeine and coffee nuts, right? However, I would say this isn't a card, to give you that, that go ahead to just go nuts drinking your coffee, because there's other things that are downsides to excess caffeine consumption. When we talk about sugar in drinks, let's get to the sugary drinks. 1 glass of orange juice is the equivalent to 5 to 6 oranges. So all sugar is not the same. When you're talking about sugar consumption in the form of fiber, your fresh fruits, what's good about that is about 30% of that sugar is not absorbed. And that bulk from the fiber makes you full. So you're not going to eat 6 oranges, right? Doubtful. But if you drink a fizzy drink that has a lot of sugar in it, or orange juice, you can more easily find yourself drinking multiple glasses of that and consuming way more sugar than you should. When we talk about sugar, sugar is likened unto cocaine. It hits parts of the brain that lights up and causes dopamine release. And that's the problem with even the internet and social media and all that. You keep going on there and you hit, you look, it lights up the happy centers of your brain, and it makes you want to keep doing it. It's kind of like gambling. You just keep coming back and it becomes an addiction. And that's the same thing with sugar. So you can become a sugar addict. And I think the majority of our society falls in that category because we were born and raised on sugar. And that's manipulation of, advertisements and commercials and things. Sugar accelerates aging. It can impact skin conditions. It can cause poor dentition. It can hit the arteries around the heart, damage the heart vessels, can go and convert to fat and then infiltrate into the liver and cause fatty liver. It can hit the microbiome, that healthy organisms in the gut, and that's your protective, layer in terms of, development of diseases, inflammatory conditions, autoimmune diseases. If you disrupt that through excess sugar, the microbiome becomes monotone and it's not diverse anymore, and it isn't as protective. It can hit the pancreas, and cause the pancreas to go into overdrive. And, after a while it gets tired and it says, I can't do it anymore. And it doesn't produce as much insulin. So that's why it's important when someone says you're pre-diabetic that you get on it early so that you can preserve pancreatic function so that it's not working, in excess. It can hit the kidneys and cause kidney damage, even permanent damage later on down the line. It impairs reproductive function in both men and women. When you're talking about non-sugar sweeteners, it's a no-no. So the World Health Organization in June of this year actually put out a consensus statement saying that we should not use these sugar substitutes, these artificial or natural non-sugar sweeteners for weight loss or for prevention of diabetes or to manage your sugars. It has been shown to actually increase your risk of developing diabetes or cardiovascular disease in some people. There has been some association in some studies, even of saccharin and bladder cancer, for example. You can have some preterm birth risk associated with it, and fat distribution in your fetus in pregnant women. It's just a bad thing overall, and you're just swapping one bad thing for another. Rather than doing that, cutting down on your sugar without using non-sugar sweeteners by reducing your overall sweetness of your diet is the way to go. And another thing, I know early on, when the market was being flooded with these non-sugar sweeteners, I was one of the ones that was using it too, to try to substitute, thinking that it's a healthier option. We found out that it can impact, sugar can go and impact the brain. Leptin and ghrelin is two hormones that are your satiety hormones. They're the hormones that tell you to stop eating. You're full, you don't need to eat anymore. But when you do these sugar substitutes, it can go and blunt that effect, and you can still feel hungry even after or beyond the amount of caloric intake that you should be consuming. Because and there are chemicals in our foods that these industries, they know about, they add it, in chips and different baked goods and things, and you just keep eating and eating. And then after a while, you're like, oh my God, I ate the whole thing. How did I get here, right? But you got there not only because of, some choice that you made, because a lot of people will like to blame victims, but you got to think about what's happening chemically in the body that allowed you to get there. And the blunting of those hormones and blocking of the communication between your gut and the brain can contribute to your eating the whole bag, and doing that over time, you gain weight. There are certain medications that are associated with elevations in sugars. Statins, which are, our bread and butter as far as heart disease and protection. Lovastatin, pravastatin, atorvastatin, you've heard of them, are associated with elevations in sugar, but it's a low risk, and you have to put it in context. If the benefit outweighs the risk for the medication, then you should use it. You should take it. Like, say if you're told you're pre-diabetic, and then you ask your doctor to calculate your risk score, your atherosclerotic cardiovascular disease risk score. There's a lot of words, right? But if you have them calculate your risk of having a heart attack 10 years from now, and it's moderate to high, then you should go on that statin. If it's low and you're pre-diabetic, I would say hold, go on a holding pattern and not go on it. If you are diabetic, you should be on it, because diabetes is almost the equivalent of having had a heart attack. It's that significant. Blood pressure medications in the beta blocker class of drugs like atenolol and metoprolol and propranolol have been associated with elevations in sugar. Not carvedilol, which is a popular one that we use for heart disease these days. Again, if you have high blood pressure, you need to get that high blood pressure treated, because it's like a recipe for disaster. If you have diabetes, cholesterol, blood pressure, you're like, I'm not gonna take any of this because this can cause badness. Well, what's worse is not taking that, not addressing the issues, not controlling the blood pressure, which is a benefit that outweighs the risk, will lead to other things like stroke. And I've seen, especially among my African-American patients that come in, where there's pushback on starting blood pressure medications because you don't feel anything. You know, I feel fine, I'm great, my blood pressure is always high. Well, that's not good. It's a silent killer, and you feel it when irreversible damage has occurred, such as I'm telling you, you have kidney disease now, and you're, you know, advancing towards dialysis, or I'm telling you, or you're presenting to the emergency room with signs and symptoms of stroke. Diuretics can be associated with elevations, and steroids, and that's a big one. You know, we prescribe steroids for people with lung diseases like COPD or asthma, autoimmune diseases, various things that we prescribe steroids for. But again, the risk benefit analysis is what determines whether or not you should be on it, not the fact that these things occur. But I'm telling you this so that knowledge is power. So if you start seeing elevations in sugars and you look and you see that you're on particular medications, you can have those conversations with your doctor. There are different medical conditions associated with diabetes: obstructive sleep apnea, fatty liver disease. If you had pregnancy-related diabetes, gestational diabetes, that increases your risk of developing diabetes postpartum. Cardiovascular disease is associated with increased risk. High uric acid, if you have gout, hyperuricemia, and they got you on gouty medications to bring the uric acid down. High uric acid itself can be associated with higher risk of developing diabetes. I mentioned metabolic syndrome earlier in the discussion, and with metabolic syndrome, we talk about abdominal circumference, obesity. We talk about blood pressure elevation, sugar elevation that may not quite meet the criteria of diabetes. So you're like pre-diabetic, and elevations in your bad cholesterol. Say your good cholesterol, your HDL may be low, and your bad cholesterol, triglycerides may be high. All of these things collectively constitutes what we call the metabolic syndrome, or insulin resistance, or syndrome X. And insulin resistance syndrome is the thing that we're talking about now. When you gain weight and your body doesn't respond to the insulin, when you take in, a meal that has sugar in it, and that later on down the line causes your pancreas to have to work harder, and high insulin, more weight, it's like a cycle. It just feeds and feeds until you end up having full-blown diabetes. Polycystic ovary syndrome, on the OB-GYN side, just to mention that, also is associated with insulin resistance and development of diabetes. And I wanted to mention breastfeeding, because breastfeeding is actually a good thing. It negates the risk. It reduces the risk of diabetes. So diabetes in and of itself is diagnosed in the same way with those same similar tests that I mentioned earlier for prediabetes. You can look at a fasting plasma glucose, if it's at 126 or higher, and you do it on 2 separate occasions, that gets you to the diagnosis of diabetes. If you drink that sugar load, the 2-hour oral glucose tolerance test is 75 grams of sugar, and you test 2 hours later, if the result is 200 or higher, and you have to do it twice, 2 separate occasions, because you want to confirm. You don't want to label somebody with diabetes who really isn't. So you really want to test twice. The third test is the hemoglobin A1C, which I mentioned before. That tells you your average sugar over the previous 3 months. I mentioned that the hemoglobin A1C is that sugar attached to the red blood cell. As long as the red blood cell is floating around, the sugar is floating around. So it gives us a gauge of your average blood sugar over the past 120 days or so. If you hit 6.5 or higher, and you test again and you hit 6.5 or higher again, that's diabetes. And we know that there's various complications: cataracts, glaucoma, periodontal disease, heart disease, strokes, kidney disease, which we call diabetic nephropathy, peripheral vascular disease. We have poor circulation and decreased pulses in your lower extremities. You don't get good blood flow down there. That can lead to limb loss. Nerve damage also can lead to limb loss, because you don't feel when you bump your foot. You've lost the sensation in the nerve and you tap that toe against something and you don't know it's there. And that happens over time and it opens up a wound. And that's how you start seeing people with diabetic foot ulcers. And that can progress to amputations, which is pretty high disproportionately among African Americans. So strategies for prevention, we can maintain a balanced diet, and we say that generically, but, there's no magic bullet. I'm not going to, tell you, well, I can tell you some things, like hibiscus and different things that you can go on naturopathic routes for, but that's not going to do the heavy lifting. It might be a drop in the bucket to what you really need to reverse the situation. So you have to have clean eating, clean diet, fruits and vegetables, a rainbow of fruits and vegetables, not corn, not potatoes. Those are starchy, that's bland. You want the rainbow on your plate of fruits and vegetables. And remember, we talked about the various fruits that are good and those that are bad in terms of contributing to increased risk of diabetes before. Eating more brown rice instead of white rice, or more lean protein, more fish, less red meat in your diet. Exercising, physical activity regularly, 30 minutes a day, just walking the block, walking around, gardening, doing something for 30 minutes per day. It's heart healthy, it's weight healthy, it's brain healthy, it's mental health healthy, because it causes firing so that you are in a better place mentally. So if you suffer from depression, that can also help. It helps in so many ways. Managing your weight through the balanced diet and being physically active, limiting your sugary drinks and your processed foods, choosing water or unsweetened beverages, and opting for whole and unprocessed foods are all ways of preventing or even managing once you've been diagnosed with diabetes. Diabetes management, and as we come into the home stretch here, monitoring your blood sugar levels. And that looks different for each person. When you first are diagnosed, depends on the severity of your disease, how high your sugars are, how many medications you're on, if you're on insulin or not. That will determine how often you have to check your own sugar at home. And typically we start with the fasting sugar though, in the morning, because that's telling. If your fasting sugar is up, then everything else is probably up, right? And especially when you're trying to ease someone in who's a newly diagnosed diabetic, you don't want to scare them off, especially if they're needlephobic and they're like, hesitant to even going in this direction to begin with. You can ease a person in by just checking the fasting sugars in the morning and seeing if they hit, the levels and making your adjustments based on your fasting sugar. More data is better though, in terms of hitting it early as far as lowering your sugars and trying to get it under control as quickly as possible. That's better than what we used to do, which is very slow go, and every 3 to 6 months we're making adjustments. That's time lost, and that's tissue and organs potentially lost, because that toxin, that high sugar, excess sugar, is doing its damage silently. It's not holding up and saying, I'm going to wait until you mentally can get it together to get on board with treatment. It's going to do what it's going to do. So getting in and having those conversations with your mental health specialist, with a nutritionist, with different people, so that you can really come to Jesus about, what's going on in your body, and not be so super spiritual for those of us who are believers, where we say, well, I'm not going to claim it. Well, you don't claim it, but your body is going to continue to do what it's going to do. I do believe in healing. I am a minister. I do believe that God can do things, but God doesn't go against natural laws, right? So when you get to the top of a building and you jump, gravity is the law that is in operation when you jump off a building, and you're going to hit the ground.
Message. Can I
call
in about 10 minutes?
And I think someone has their phone unmuted. If you can put your phone on mute, that'd be great. Taking your prescribed medications as directed, making sure that your doctor explains the side effects, the time of day of use, if what you should do if you forget to take your medication, doing things like pill, they have the pre-packaged meds. If you tend to forget, you can get it packaged and delivered to you so that you can have Monday, Tuesday, Wednesday, Thursday, Friday, and not have and take the guesswork out of it, where you can get a pill dispenser. You can use your watch and put an alarm on so that you can remember to trigger to take your medications. It's very important. Most of the heavy lifting is done on the side of the patient, not in the examination room where you have 15 minutes with your doctor and then like, okay, see you. That isn't where the heavy lifting is done. It's the choices that you make in terms of getting more numbers. The more numbers that you do in terms of testing, the better, because it'll give us a better sense of how your body is processing these sugars. And there's different medications that will target pre-prandial, meaning before meal, versus postprandial, after meal sugars. So we can tailor it specifically to your needs, as opposed to being generic and having to guess and stab in the dark because we don't have as much information. Taking your prescribed medications and being truthful. You don't hurt anybody but yourself when you go into a doctor's office and not reveal if you're doing something right, if you're sticking to the diet. Portion sizes are important, and not overeating and eating nutrient dense foods, healthier foods, and not processed and fried fatty foods. Walking 30 minutes a day or other physical activity like you do with the Soul Steppers, that's important. Annual eye and foot exams are important, so make sure your doctor sends you for both of those things so you can check for early evidence or early signs of damage to the eyes from your diabetes, or loss of circulation, decrease in your pulses in your feet, or nerve damage, from decreased sensation. These things can be tested at the bedside. Immunizations are important, very important to keep up to date when you're a diabetic, because infections tend to be more rip-roaring and damaging in someone that's a diabetic than someone who is not. And I am so proud of myself. It's 10:51. So I'm going to stop there and hand it over to Antoine. I see some things in the chat.
Yeah. Yes, Dr. Cosette, thank you so much. A lot of great information. And I know the chat, there were some comments and things people were making. Before I get into the questions, one of the things one person mentioned was about access to the slides. So I wanted to make an announcement. We'll work with Dr. Cosette to be able to get her okay to be able to share the slides in the deck.
Yeah.
We will, as I mentioned before, we are recording this, so we will put the recording in the private group. And I'll work with Priscilla, who's on as well, to see if we can maybe get it on our YouTube page for AARP California. That way folks will be able to access it. But we'll be sharing this information also to all of those who attended, sharing the recording as well. So the question, there was one I wanted to, where did it go? Oh my God. So this is why I don't.
Yeah, I'm looking through it now too. So
So
someone wanted to know about sugar substitutes a little bit more. That was one question. With sugar substitutes, you have simple sugars and then you have more complex sugars. So you have monosaccharides and disaccharides. Monosaccharides are like your glucose and fructose. The monosaccharides are easy for the body to absorb. Your body doesn't have to do any extra work, to absorb that. So when you eat fruit, for example, those are simple sugars. Those are easy on the body for digestion. The disaccharides are the other, sugars, your sugar substitutes and more complex sugars like you have in baked goods and sweets and sugary drinks and all that. It makes the body have to work harder because it has to break it down from the two, component sugar to the simpler sugar before it can even absorb it. And excess sugar in the body, like one can of soda is your whole day's allowance, of sugar for the day. And there's hidden sugar in everything. You look at your bread, there's sugar in there, there's sugar everywhere. So you have to be very aware about where hidden sugar is. Sugar substitutes can blunt your ability to know when you're full, and you can actually end up gaining weight with sugar substitutes. There are some sugar substitutes that have been linked to cancers, like I mentioned, saccharin in bladder cancer. It's not overwhelming data, but it's still out there. And it's just like we're going from being a meat eater to being a vegetarian or vegan. We substitute, with all this fakery, stop the fakery. If you're gonna do it right. Go for it, go hard or go home, right? Is what they say. When you go and you get all this tofu and all this processed stuff, then you're setting yourself up for other issues, so you want to be clean with it. With these different sugar substitutes, though, they are not, like I said, the WHO, the World Health Organization, this year put out that consensus statement saying that non-sugar sweeteners, these sugar substitutes, whether they're natural or artificial, because they say natural and you think, oh, I'm safe, it's natural. Natural is not natural for you. If it's not already in your body, that's not natural, right? So when you're looking at these things, they're saying they're not to be used for weight loss. They're not to be used to reduce your risk of diabetes or to lower your sugars. That it's better for you to just address the problem at hand, that we consume too much, sugar, period, as a society, and we need to address our addiction. Let's see.
There was another question, Dr. Cosette, about, one comment from someone who said that they're looking for an internist or a referral and if you were local. So that's, yeah.
I have a website, drcosette.com. When I make a decision, right now I'm on sabbatical and I'm enjoying life and doing things like this because I couldn't be here in the middle of the day as easily. I make it happen, but it wouldn't be as easily as I'm doing today if I were working. So I'm actually on sabbatical, writing and about to be published, different things. So when I decide where I'm going to next, I'm going to post it. It'll be everywhere on social media, but drcosette.com is my website and I'll put it there.
Perfect. Someone did have a question. What's the word on kombucha?
Oh my God, kombucha hurt my heart. So I was a kombucha addict, right? Just drinking that stuff. And one day I was just wondering what the heck is going on with me. I was hot flashing like a big dog, just hot, just sweating. And I'm like, what is happening here? Kombucha has caffeine in it. It has black tea and green tea in it. It has sugar in it. So they they always find a way to make something that could be good for you bad. Water with a squeeze of lemon, water with a squeeze of oranges. I freeze my fruit, especially when it's overly ripe and you're about to toss it, freeze it and throw your frozen oranges into your water. Throw your frozen cantaloupe, frozen pineapples. This is so yummy with some cucumber. Yummy. I would say go there. Kombucha, fermented things and probiotics and all that. We have yet to see the full extent of impact on health, to tell you honestly. There's certain instances where probiotics and using these additional organisms, in your diet are of benefit. So say if you have, you just had a cold, you had COVID, you want to rebuild your immune system, you want to rebuild your good flora in your gut, then maybe 30 days on the probiotic is good. And getting fermented, like Greek yogurt and different things would be helpful. But kombucha in and of itself, is expensive. It's tasty, but it's another addiction in my opinion. It has sugar and it has caffeine and I can't say that it's something that's good. Continuous blood glucose monitors are accurate. They are helpful if they're used right. And if you are taught, how to interpret that information, meaning if you have it on, but your doctor really isn't going in and looking at all the data, then it's not useful. But if you are someone who is on insulin, especially, you're on insulin pumps, it's a lot of noise in the background right now, I'm sorry. Those patients would particularly benefit. If you are brittle diabetic and you have highs and lows and you're all over the place, labile sugars, unpredictable sugars, no matter what you do, it might be because you're not eating, regular meals, spaced out or consistent meals or whatever. All of these things would be beneficial to have the continuous glucose monitor. So I believe it is helpful.
And then one more question too is about, as we come towards the end or the top of the hour, what's involved in a foot exam related to diabetes?
That's a great question. A foot exam related to diabetes is two-pronged. I would say even three. First, you look at the skin to see if there's any skin breaks. Make sure there aren't any sores, scabs, openings, or wounds, because that could be a harbinger for something more serious if it goes undetected or untreated early on. Checking the pulses, put your 2 fingers on there. There's a dorsalis pedis and posterior tibialis. That's right there on the front of the foot, the top of the foot, or on the back of the ankle area on the side, are the 2 locations. If it's reduced, then there's a chance that there's some plaque buildup. You get calcifications more easily in diabetics, and that hardens the arteries there. And the blood flow and the oxygen flow to that limb is diminished, and that predisposes you to limb loss later on down the line. Nerve damage, the other way of testing for that, they have this monofilament, this little small wire, it doesn't hurt, and they will touch different areas on the bottom of the foot. And depending on, your response, that will let us know if you have diminished sensation there, if you have the potential of having had nerve damage already because of uncontrolled diabetes or just the presence of diabetes. Beyond that, you can go and send a person out. They can do blood pressure checks, ankle brachial index is what we call it. And we can do that in the office where we check lower extremity blood pressures, and we do this ratio, and that can give us a gauge as to whether or not there's a circulation issue that's going on down there. Or we can send you to radiology and actually take a look at the vessel itself to look at the flow and to see to what extent there's been a narrowing of the vessel to that foot or that leg. And that will tell us where you are in terms of risk and whether or not we need to refer you out to a vascular surgeon for further management. So those are some of the ways that we can examine the lower extremity and the foot in particular.
Thank you so much, Dr. Cosette. I know we could probably go on for another at least hour,
Yes.
but yes, we definitely appreciate your time joining us this morning and sharing this information, because it's been very, very good, very helpful, very beneficial. Some thank yous that are in the chat right now are popping up. So I think the audience agrees with me that this has been very, very helpful information. And we, as I mentioned before, we did record this, so we'll put the recording in the private Facebook group. We'll see if we can get the recording on our YouTube page, and then also share the deck with those who were in attendance, so that folks will have access to this information and also have access to Dr. Cosette, and her link to the website that she mentioned. Her web page is in the chat as well. Priscilla dropped that in there earlier for you guys, so that you'll be able to click on it and get more information about Dr. Cosette. But again, we just thank you. We appreciate the time, especially because I know when I reached out to you, being on sabbatical, I know what that's about. So hopefully you're enjoying it, and we will definitely reach out to you again and come back and talk to the group about other things in addition to diabetes. We try to do a workshop once a month and have a different topic. So I'll be reaching back out to you, of course, very soon, but respecting your time away.
Thank you. Thank you, everyone. It was great to be with you.
All right, everybody. Thank you, and have a great rest of your day.